The most recent guidelines for the management of axial spondyloarthritis, Axial SpA, have been updated by the Assessment of Spondyloarthritis International Society, ASAT, and the European Alliance of Associations for Rheumatology, EULAR, in 2022. These guidelines include several key recommendations for the treatment and management of Axial SpA, which are designed to improve patient outcomes through personalized and evidence-based approaches. Key recommendations: 1. Personalized medicine. Emphasis on individualized treatment plans that consider patient preferences, comorbidities, and disease characteristics. Regular monitoring and adjustment of therapy based on disease activity and patient response. 2. Non pharmacological management. Regular physical exercise and physiotherapy are strongly recommended. Patient education and support programs are essential to help manage chronic disease. 3. NSAIDs as first-line treatment. Nonsteroidal anti-inflammatory drugs, NSAIDs, remain the first choice for managing pain and inflammation. Use of NSAIDs should be tailored to the individual patient's needs and tolerability. 4. Biologic DMARDs, BDMARDs, and targeted synthetic DMARDs, TSDMARDs, indicated for patients with elevated C-reactive protein, CRP, MRI-detected inflammation, or radiographic sacroiliitis who have high disease activity, AST/AST or 2.1, and have not responded to at least 2 NSAIDs. Tumor necrosis factor inhibitors, TNFI, and interleukin-17 inhibitors, IL-17I, are preferred, with JAK inhibitors, JAK-I, also being an option. Treatment should continue if a significant improvement, AST/AST or 1.1, is observed after 12 weeks. 5. Glucocorticoids and conventional synthetic DMARDs. Long-term use of systemic glucocorticoids and conventional synthetic DMARDs like methotrexate is generally discouraged for axial disease alone. 6. Management of extramusculoskeletal manifestations. For patients with recurrent uveitis or inflammatory bowel disease, TNF monoclonal antibodies are preferred. IL-17 inhibitors are recommended for patients with significant psoriasis. 7. Treatment reevaluation and adjustment. In cases of treatment failure, a reevaluation of the diagnosis and consideration of comorbidities is recommended. Switching to another BDMARD or TSDMARD is suggested if the disease remains active despite initial treatment. 8. Surgery and spinal fractures. Surgical intervention should be considered in cases of severe structural damage or spinal fractures not responsive to medical therapy. 9. Tapering of biologics. Tapering but not abrupt discontinuation of biologics may be considered for patients in sustained remission. These guidelines aim to optimize the management of Axial SpA by incorporating the latest evidence and expert consensus, thereby improving patient outcomes and quality of life. 30 source, 31 source. For detailed recommendations and comprehensive guidance, refer to the full guidelines published by ASAS EULAR.